Why? Because we're not listening to the patient. We're not listening to what we're doing wrong, and we're getting ready to make the same mistake again. 16 million of them. And so why are ERs loaded with kids with an ear infection when they're already Medicaid eligible? Because we haven't oversighted, and neither have the states, in terms of enrolling those people to where they have a primary care. And we have a Medicare payment system that says if you're a medical student graduating in this country, you don't want to go into primary care because there's a 300% payment differential versus you spending another year or two in training, you'll make 300% more. So only the most altruistic of our physicians go into primary care. It's obviously not about money because they could be an engineer and make twice as much with less time and a lot less school debt. So I would just ask my colleagues is, as we walk down this, I agree to walk with you to truly fix the problems. Senator Mikulski and I have a totally different look at cost comparative effectiveness. You know, I'll tell you the other reason I think healthcare in this country is pretty good, and it's good for my Medicaid patients and my patients that don't have any health insurance. Because when somebody gets cancer, most of the time we get them well. Most of the time we get them well. Some fall through the cracks, that's true. But as a two-time cancer survivor, I think this healthcare is pretty damn good. I think it's pretty dang good. I have atrial fib. If we have what Dr. Mikulski wants to do on comparative effectiveness, I've been through 7 medicines trying to get it controlled. But if we follow comparative effectiveness, I'd never got to the 7th medicine. It had just been tough. I'd been on digoxin, take Coumadin the rest of my life, and run around with atrial fib, which would cut my life expectancy about 7 years. We're not going to ever consider that because comparative effectiveness denies the art of medicine. It denies that we will use Chairman Dodd's gray hair, somebody's long-term education, their wonderful years of experience, and the history of that patient with which to make a decision that is best for that patient, not which is best to save the government money. And that's what comparative effectiveness is. Clinical comparative effectiveness is a totally different thing. We spend hundreds of millions of dollars every year paying for programs on long-term studies through the NIH to find the answers to clear questions. But to think we're going to have some ivory tower bureaucratic doctors look at the data over a short period of time and tell the rest of America what's good for them and what's wrong, that's poppycock. And what it's set up for is so that we can manage the costs, so that we can ration the cost of care in this country. There's nothing wrong with a single payer system, but just remember the way you control the cost in that is deny care. And that's what England does. That's what France does. That's what Canada does. They deny care. We're going to make an assessment in Washington about how much your life's worth, and then we're going to tell you whether or not you can have the care. That's where we're going with this. There's no denial of that. I mean, if we're going to do cost comparative effectiveness, we're going to tell you what you can and cannot have or what is recommended under the Washington-based insurance plan. And we're going to do that in Medicare. And we're going to do that in Medicaid. Just remember, we're rationing right now in Medicare. Seniors, if you're out there, listen to me. If you've got a complicated health condition and you need to have a colonoscopy, no longer as a Medicare patient can you have a virtual colonoscopy that puts you at almost zero risk. You now have to have a procedure that puts you at greater risk, that actually costs more. But because somebody in Washington decided that was too expensive. If you have lymphoma or leukemia or cancer and your blood count that drops, don't forget that your doctor doesn't get to really make a decision about when you get erythropoietin, something to bring your counts back up, because Medicare has already decided when you can have that and when, without consideration of your concomitant other health problems. That's where you're walking with this. If you like that, if America likes that, then let's do it. But just remember, it's rationing. We're saying you're not worth great health care. I think every American's worth great health care. And I think competition in terms of professional quality, in terms of delivery of services, and competition among the insurance industry is not where it should be. And I think we ought to drive it where it should be, because I think it'll help us allocate resources. Nothing should happen to somebody like Patricia Irvin, that Senator Casey talked about. We failed. But we created a lot of the inflation in health care by cost shifting Medicaid and Medicare costs onto the cost of private health insurance. It's at minimum $1,800 a family a year. Because we won't put the money into Medicare, we've made private health insurance cost $1,800 more per year per family. So you get to pay 3 taxes in this country. You get to pay your Medicare tax, then you get to pay your income tax, and then you get to pay a whole lot more for your health care because we have government programs that we refuse to fund adequately or manage properly. That's the truth, and you cannot deny it. We have cost shifted hundreds of billions of dollars into the private sector. The other problem that I see that I want to share is this assumption that we know best. You know, we don't. We're tasked with a mighty, mighty task if we're going to adjust health care. We don't know, we haven't begun to know what we need to know to make the decisions that have to be made on health care in this country. And the idea that we're going to do this in a fixed period of time to put a fire out with a very high risk of getting it wrong, to me, it doesn't compute. None of us want to hold up fixing health care. None on my side of that. We agree there are big problems and there are people who are suffering because we haven't fixed it. But to pretend that what is on the table is not going to take away the insurance that people presently have that they want, even CBO agrees with that. It's going to drop it like a rock. So you can take CBO having half the information, or you can take the Lewin Group, which says 119 million people are going to lose the insurance that they have today that they want to keep. Both of those, we rely on them. They're fairly reputable. They don't have a pig in this football game. Why would we take a risk of that if, in fact, we really want people to have what they want? I'll close with a couple other things. What is behind the scenes in all of this that nobody will speak is mandatory physician participation in government programs. That's what's coming. It's thought about. The Kennedy staff talks about it a lot. Massachusetts mandates it. That's what's coming. We're going to say we're going to create a government program, and if we don't get enough people participating in it, we're going to pass a law that says you have to. Can we fix health care and still let true liberty and freedom survive? I think we can. It's hard work, freedom. It's hard work depending on what we know works in terms of setting forces at odds with each other to get the best quality at the best price. It's hard work. But it's coming. We're going to tell everybody what they have to do. And we haven't even begun to talk about what Senator Sanders would like, which would be all the physicians working for the government, because that's what they do in all the other countries. They work for the government. Our average federal cost today, as of yesterday, for a federal employee is $119,000 a year. Twice what the average cost is for everybody else that works in this country. That has great implications in terms of why the cost of government is so big. Finally, I would say this, and this is my last final, Mr. Chairman. If you want everybody covered with quality care, and you want everybody to have affordable care, and if you want to make sure we incentivize prevention so we control costs so that we can truly manage chronic disease, if you want to make sure nobody ever goes bankrupt, nobody ever loses their home over health care, if you want to eliminate the tragedies of Patricia Irvin, if you want all children covered and immunized and having well child visits, if you want the states to save at least $1 trillion over the next 10 years, and if you want to not spend the $1 trillion that's in this bill, and if you want to preserve the medical innovation that this country is known for, read the Patient's Choice Act. Just read it. You don't have to agree with it. Nobody on the other side of the house has done that. Haven't even looked at the ideas of innovation in terms of satisfying the trial lawyers but still lowering court costs, still lowering liability costs. We just transferred $250 billion a year in defensive medicine because we have an uncontrolled tort system in this country. And yet we don't offend the trial lawyers with this way of looking at it. Just read the bill. If you want to eliminate low birth babies, read our bill. It does. It takes every Medicaid patient out of Medicaid and gives them real insurance with real choice at the highest quality level, at the highest quality hospital every time. If you want to solve the healthcare quality problems, read our bill. At least look at it. Consider it. Don't just reject it out of hand. And if you want to do what's right in this country, for this country, let's slow this process down and let's make sure we got the input of all the innovative minds in this country, whether it be prevention that Senator Harkin and I are interested in, whether it be working on school lunch programs or food stamps so we don't pork everybody up because we're giving them junk. Read the bill. If you want a veteran to get real help, what was promised to them, health care, give them the choice to go wherever they want. If you want to honor your commitment to the tribes through the very treaties that we have, and you say we're going to give you health care, then give them a card and let them go wherever they want. And make Indian Health Service have to compete with them. Give them real freedom, but also meet the commitment that you've made to them. Today, we take Indian Health Service and we underfund it, we undercare, and then we have the pictures every year given by our colleagues from North Dakota and South Dakota about how bad it is. Yet we don't give them what we promised in the treaty we would, is access to affordable care. Let me tell you, access denied is care denied. Having to wait is care denied. We can live up to our commitments, and we can do all of it and not spend a penny more. And we can get everybody in this country covered. We can eliminate low birth babies. We can do the prevention we need. We can control chronic disease. But we can't if we won't listen and talk to each other and talk to the people outside of Washington who know what the heck's going on, like Dr. Cooper in Texas. Just look at what's happening in El Paso in the schools. They put an exercise program in there that has dropped BMIs, dropped the dropout rates, raised education, decreased drug use, and increased graduation rates. Just through exercise, because the new neuroscience today says that you learn 20% more if you've been exercising before you go into class. But we ought to incorporate all that, all the incentives to help us do what we want to do. But we haven't taken the time to listen. We've said we got to be on this schedule. So my appeal to you is, I honor you for your desire. You have the same desires I do. How we get there is very different. And I would remind you of the 3 tenets of medicine. Listen. They'll tell us what's wrong. If it's been done, don't do it again. And for God's sakes, don't do any harm. Thank you, Mr. Chairman.
Thank you very much.